discussion.
Okay, can everybody hear me? Yes, hopefully.
Yep, we sure can.
Okay. All right, I'm gonna go pull up my PowerPoint. Hopefully this works. Okay. So today I chose the topic of vitamin D in chronic kidney disease, and we're going to cover Dr. Parker and co.'s paper from a couple years ago, and actually they just recently, hot off the presses on your JVIM early view, Dr. Parker was kind enough to email me her pre-copy a week ago. They came out with a follow-up paper to this paper, so it's actually a pretty timely topic. And I chose this paper because I struggle with this a little bit. I struggle with the pathophysiology of hypovitaminosis D and renal secondary hyperparathyroidism. I think that, monitoring this and, keeping an eye on everything and when we treat, how we treat is still pretty not clear, and I obviously want your guys' input on that as well, but at least from my perspective, this is something that we're still not quite understanding of in terms of the pathophys and what our recommendations are going to be for these creatures. And similarly, in human medicine, this is also something that they're still not 100% all in agreement on how we handle this. So hypovitaminosis D is associated with the development of renal secondary hyperparathyroidism, chronic kidney disease, mineral bone disorder, and increased mortality in people with chronic kidney disease. But there is little known about the role of vitamin D metabolism in dogs with chronic kidney disease. So the objective of this paper was to further elucidate vitamin D status in dogs with different stages of chronic kidney disease and relate it to the factors that can affect the development of CKD, MVD, such as parathyroid hormone, FGF23, calcium, and your phosphorus concentrations, which are kind of all interrelated here. And it was a case-controlled study. They looked at 37 dogs with chronic kidney disease in IRA stages 1 through 4 versus 10 healthy control dogs. We'll get into that in a minute, just in terms of their study design. They looked at several different metabolites, 25 hydroxy vitamin D, 125 dihydroxy vitamin D, and the kind of post product of vitamin D metabolism, which is 24, 25 dihydroxy vitamin D, PTH, and FGF. And they were looking for concentration or an association between each of these vitamin D metabolites and their IRA stages. So kind of wanted to take a minute there and see what you guys thought about that. I was a little bit concerned in terms of their study being a case control. One of the things that you'll see in the paper is that they did only 10 healthy control dogs, and they weren't age matched. They did say that there has not been an association of vitamin D status in age as long as the dog is, I believe, a year of age. But I thought that would have been a nice thing to do, age match, potentially even try to breed match, but wanted to get your guys' thoughts on that.
Like with 10 control dogs, there was probably an opportunity to select them a little bit better in terms of matching the population. It's always a challenge, especially when the numbers are low, to do that in a way that doesn't, again, create a different bias, since it's not necessarily a random population, but if you're specifically looking for a dog. But I think the low numbers just bring up the questions of, how representative are the control population dogs of the entire control population, and maybe it is,
exactly.
maybe not quite as much as we'd like it to be.
Yeah, 10 seemed like kind of a few number to me, but obviously something that could be expounded on later. But otherwise, I thought this was a reasonable study outline. Just to not go into this with too much detail, but this was courtesy of Dr. Parker. So thank you, Dr. Parker and OSU and co. I thought this was a very, very well done kind of outline of all the different factors and vitamin D metabolism that happen. So just kind of a quick refresher. Diet, primarily cholecalciferol in our canine population, which then binds to our vitamin D binding protein, which that does become important. And then within the liver, we have 25-hydroxylase that converts your calcidiol or your 25-OHD into your 125-OH2D or your calcitriol, which is the more active form. And there is some evidence that as chronic kidney disease progresses, we start to lose a lot of that, and especially at the level of the 1-alpha hydroxylase enzyme. So not to belabor this too long, but just I thought this was very well done. And just to look at all of the different factors that kind of come into play in this, you know, we have PTH, we have calcium levels, we have FGF-Klotho, we have all of these different factors that can kind of come into play here depending on what stage of renal secondary hyperparathyroidism we're at. And then again, I thought this was a really good review for anybody like me who is struggling with the pathophys on all of this by Dr. De Brito-Galvao. Again, just looking at all the different factors that can kind of come into play here. And as that calcitriol decreases, we get kind of upregulation of our parathyroid, which can sort of further along that sort of destructive cycle that progresses our chronic kidney disease and our development of renal secondary hyperparathyroidism. And that kind of was recently not 100% known. What we thought was that as the kidney failed, we lost more and more of this calcitriol, but now we're realizing that it's a lot of combination between the loss of kidney mass as well as also the sort of upregulation of these other factors like FGF23 and the upregulation of our alpha-1 hydroxylase enzyme and all of that good stuff. So I don't want to go into this too much. I don't know if anybody had any comments on any of this stuff for right now. Nope. Good. Moving on.
Hey, Caitlin.
Yep.
The one thing, if you wouldn't mind hitting hide on the bottom of your screen, just so you're, yeah, perfect. That way,
there we go.
Just takes a little bit away. Perfect. Thanks.
Oh yeah, no problem. Can you guys, like, you can still see everything, right?
Over
okay.
to, I think, a different desktop when you did that.
It went away. Okay, hang on. Okay, is that better?
Yep, perfect. Thanks.
Okay, yes, thank you. So yeah, again, kind of just to go into a little bit of the pathophysiology of this, you know, I think our knowledge of how this progresses has definitely changed recently with the sort of discovery of FGF23 and all of those associated pathways. Okay, cool. So this I thought was crazy from Dr. De Brito-Galvao's review, all of the different effects of calcitriol on the body and kind of what happens when we have dysregulation of calcitriol in part of chronic kidney disease and renal secondary hyperparathyroidism. So this was just fascinating to me, all of the different things that can start to happen, you know, in terms of a lot of areas that we're looking at in both vet med and in human medicine, such as megalin expression, which that is responsible for moving vitamin D into the renal tubules, so that can affect our vitamin D synthesis, decrease of the RAS activity. There's been a lot of research looking at the antiproteinuric effects of vitamin D levels. So just all kinds of things here that can play a role in terms of the pathophysiology of vitamin D and its role in chronic kidney disease. All right, same thing kind of. Again, we really didn't have a lot of knowledge about this. This is sort of the old way of thinking with the renal mass theory, that we just thought we just didn't make enough of that calcium. And now we know that the calcium levels and the phosphorus levels can lead to dysregulation of FGF23, which can lead to decreased production of our 1 in 25 vitamin D, increasing our PTH, and all of these different factors that start to play a role here. And one of the more important biomarkers in both humans and in animals is FGF23, which we have shown are increased in cats and dogs with CKD and have been negatively correlated with both our vitamin D levels as well as survival times. So back to the study, we had 37 dogs. They were client-owned dogs. Their inclusion criteria were that we needed to have at least 2 episodes over at least 3 months of minimally concentrated USG plus minus azotemia. And the plus minus azotemia was really just because, you know, we were trying to capture some of these IRIS stage 1 dogs who potentially just only had renal insufficiency in terms of their concentrating ability, but had not yet actually become azotemic. They did also make a note if these animals, if available, had renal proteinuria and ultrasound changes consistent with CKD. I would have liked to have gotten that information probably on all of the dogs because, like we did say, renal proteinuria certainly can be affected by our vitamin D levels, and I really don't think it would have been all that hard to run like UPCs on all of these animals. But otherwise, I thought this was pretty reasonable. They tried to get a variety of dogs in different chronic kidney disease stages. They excluded dogs with primary hyperparathyroidism, primary hypoparathyroidism, PLE, neoplasia, steroid administration, and acute kidney injury. One thing I wanted to make a note of is that all of these dogs were on different diets, which they do go into in their discussion. But I think that would have also been helpful information to know, just in terms of how much intake of vitamin D these dogs were having, at least just based on their respective diets, which they tried to kind of quantify that, and that was a little bit difficult, understandably. So, all right. Anybody have any thoughts on that in terms of their methods? Nope. Good. Okay. Move on. So this was the control group, the client-owned dogs that were supposedly normal, had good concentrating ability, again, on a wide range of diets. They had 10 dogs in IRIS stage 1, 9 dogs in stage 2, 12 dogs in IRIS stage 3, and 6 dogs in IRIS stage 4, which they do say in their discussion they would have liked to have had more dogs in stage 4. And this, I think, was really a big concern of this paper, was that we really have shown that these changes associated with renal secondary hypoparathyroidism primarily start to occur in stage 3 and stage 4. So to have so little dogs in stage 4, I think, was not the best thing for this study. But otherwise, they did have a pretty good assortment of dogs. The median UPC was 0.5. They did exclude 3 dogs with suspected bacterial cystitis in that group as well. So the dogs had a ionized serum calcium within the reference range, primarily in most dogs. The calcium was low in 4 dogs and high in 1 dog. In terms of their phosphorus, 3 out of 10 stage 1 dogs had a low phosphorus, 7 were normal. 1 out of 9 stage 2 dogs had a low phosphorus, 6 out of 9 were normal, and 2 were hyperphosphatemic. And we do know that phosphorus levels can vary widely, from dog to dog with chronic kidney disease. 7 out of 12 dogs had normal phosphorus levels in stage 3, which I was really happy for those dogs. And 5 out of 12 were hyperphosphatemic. And only 1 stage 4 dog had a normal phosphorus level, and the rest were hyperphosphatemic. So the big finding of this paper was that all vitamin D metabolites were lower in the CKD dogs versus the healthy dogs, and that was statistically significant in stage 3 and 4. They had pretty good p-values. They had a p-value of less than 0.05 for their stage 3 dogs, and in stage 4 dogs, less than 0.01, I believe. So this is kind of their figure showing their different vitamin D metabolite levels. So this is for I'll click through here. Oh, did I not get that to work? Hang on. My last animation didn't work. I was going to pull all of them up individually. But anyway, so this was for 24-25 OH2D. So this is sort of the inactive product of vitamin D metabolism that was low. The more important one would really be your calcitriol or your 125 OHD, which also was pretty much across the board low. You can't see that because my other image covered it up. But anyways, they're all in the paper, and they looked pretty significant there. The other thing that they did was make this ROC curve, which showed doubling of serum creatinine concentration, which was associated with a 14% decrease in 25-OHD. And that had a pretty significant value as well. I don't think they go on to say, I don't know if anybody noted it, what the association was between 125-OH2D or calcitriol, which is the more active metabolite. Did anybody catch that? Not sure. Okay, let me see here. Oh. Nope. Okay. Anyways, so the other results were that everybody was kind of on different diets, but 17 of the dogs were on a prescription renal diet. I'm going to pull back up to my big screen here. Almost all CKD dogs got a variety of treats and human foods, so technically were not on a prescription renal diet. And because of that, they really were unable to calculate the specific amount of ingested cholecalciferol. But they did not see a relationship between the cholecalciferol intake and the 25-OHD levels. And just for our own edification, according to the AAFCO, adult maintenance diets need to have a minimum of 12.5 and a maximum of 75 international units of vitamin D3 per 100 kcal, so kind of a wide range in there. Most of the renal diet, or all of the renal diets, I should say, that they looked at had between 25 and 91 IUs per 100 kcal. So that is certainly something to kind of consider. Would be just how much vitamin D we're actually feeding these dogs, assuming that they have a pretty good appetite. So they did go into things that could cause decreased 25-OH concentration, so decreased intake of cholecalciferol, decreased absorption. So do these dogs have, poor GI absorption secondary to their kidney disease? Are we transforming less cholecalciferol to 25-OHD? Do we have proteinuria, meaning we're losing 24-OHD associated with the vitamin D binding protein? As I talked about before, do we have decreased maglin expression, so we can't even get the 25-OHD into the renal tubule where it's converted to calcitriol? Inflammation has been associated with low vitamin D levels, and then FGF23. And then in terms of factors affecting the 125-OH2 concentrations, we have the renal mass theory, which we talked about a little bit. We're simply creating less of that 1-alpha hydroxylase enzyme that's converting our calcidiol to our calcitriol, or maybe we're having increased PTH, which eventually causes upregulation of the 1-alpha hydroxylase, which ultimately causes increased calcitriol and increased calcium phosphorus absorption, which ultimately decreases your 24-hydroxylase activity. So that's kind of a whole vicious cycle that starts once we go into renal secondary hyperparathyroidism. And then the more recent findings of FGF23 playing a role, and FGF23 does have a direct role causing a decrease in the 1-alpha hydroxylase and an increase in 24-hydroxylase activity. So a lot of different factors that can go in here. So kind of wanted to get everybody's thoughts on this. To my knowledge, there is not a definitive IRIS recommendation in terms of vitamin D supplementation. When do we start calcitriol? How often do we start it? There are several good reviews out there with target goal ranges for calcitriol and things like that. And obviously we have talked a lot about phosphorus restriction in the past, but do we need to start talking more from a vitamin D level in terms of dietary supplementation, which I think is what Dr. Parker is kind of trying to go for here. In humans, they will often supplement you with either cholecalciferol or ergocalciferol, which, living in Michigan, me and everybody I know is already on vitamin D. What they are looking at in this most recent paper that just came out last week through JVIM is calcifidiol, which is an analog of 25-OHD. And the goal of that is to try to raise the serum calcidiol levels, which they did actually show some pretty good success with that in a short-term study. I think they were looking at it over 84 days, and they did seem to have some good results from doing that. In humans, there is a little bit of a debate of how we supplement vitamin D, which form, how long, all of those types of things. So I think that's probably pretty similar to what we're seeing in our canine patients here. And that's all I have for right now. I really kind of wanted to see if we could have a little discussion about what everyone's thoughts are. Do we want to start talking about doing IRIS recommendations for vitamin D levels, and when do we test vitamin D levels, and all of that kind of stuff?
Thanks, Caitlin. That was terrific. I agree. I think that there's a lot of opinions, and it seems like people tend to fall into two camps, that they're either very pro calcitriol or kind of, I guess I wouldn't say anti calcitriol, but it just might not be a common part of their management of CKD. And I'll admit that I'm in the latter. I rarely have ever prescribed calcitriol for the management of any of my patients with CKD. And I think part of it is we don't have evidence to really support that it has done anything. And I'm still find myself struggling to control their phosphorus concentration, particularly in the stage 4 patients, that there's just, it's so tough to get their phosphorus controlled on maximum doses of aluminum hydroxide and diet and adding in lanthanum and other drugs. And I worry about the effects of calcitriol increasing their intestinal absorption of phosphorus, which could maybe just precipitate the problem. But maybe that's more of just a theoretical concern rather than something that might pan out clinically. So I can't say I use calcitriol very often. I do manage patients that were started on it elsewhere, and I usually don't stop it unless they're having a problem, but I don't tend to use it. So I'd love to hear from people who are commonly using it to see what their experiences have been. And it's still in all of our textbooks as something that's recommended, but the published literature we have in dogs supporting calcitriol supplementation is an abstract from ASVN that everybody takes as gospel, showing a survival benefit from it. But that, I think, was 2015, 2003, no, 2005. Like, it's 15 years old, and it's never been published in peer review. So draw some whatever limitations you want to take from that. And then there is a survey that was published in Vet Clinics of North America that showed that, hey, vets who gave it said that they liked it and said that it helped, which to me doesn't seem like it's any justification, because it's just opinion based of vets, not any data. So I'd love to hear from anybody who uses it to see what their experiences have been likewise. Using calcitriol mainly?
So JD, that kind of was actually what triggered me to pick this topic, because I had a dog that was referred to me who had been on calcitriol, stage 4 chronic kidney disease, and they were constantly playing around at the referring veterinarian with his calcitriol levels, and his phosphorus levels were all over the place, and we really didn't know if it was making a huge difference in this dog's life. So that was kind of why I wanted to look into it a little bit more and see what everybody else was doing. So just, that was kind of my 2 cents on this.
So JD, I'll chime in. This is Larry Adams. I also don't use it very much, but I was I've certainly co-authored some things with Dennis, and we've had a lot of discussions. And I know Dr. Chu really supports it, believes in it strongly. I would comment that, like you, that we see these ones in stage 4 that are really hard to get their phosphorus under control, and we already have them on a lot of aluminum hydroxide, and even have had ones that we've had to take off aluminum hydroxide for concerns of microcytic anemia and things that we thought that was contributing. So we're changing to lanthanum or sulfonyl carbonate, maxing those out. And then we've had those patients that have stage 4 CKD after an AKI insult, and I've had several that have really struggled with hypocalcemia. So getting them to get the phosphorus control adequate to give them enough vitamin D and calcium supplementation to get their calcium back up and not be an ionized hypocalcemic patient, but yet you're struggling with their phosphorus control. And that's really frustrating. And so wondering if others have encountered very many of these, stage 4 hypocalcemic issues as well.
Yeah, I've certainly have seen that, Larry, and it's frustrating. And I think probably the biggest challenge I face in those patients is just the sheer pill burden that they're going to experience. Because in those patients, I'll probably add on the calcium-based phosphate binders like calcium carbonate, but those are not the most potent phosphate binders. And so you're now talking about having, we all see these patients that are on 4, 5, 6+ pills multiple times a day. And I think at some point it becomes just really challenging for a lot of owners that are trying to give all these medications, especially if there aren't feeding tubes in place. And it's a big problem. It's a huge problem in human medicine as well, too, where pill burden will often mean poor compliance. And that's often something that's looked at specifically with phosphate binders. There's a number of studies that have looked at how many pills you have to take if you are receiving sevelamer versus lanthanum versus whatever. And that's also an outcome that is looked at to see how few pills are there. But those hypocalcemic stage 4 patients, for me, I'm usually giving them a calcium-based phosphate binder, aluminum hydroxide at my starting dose, which is my maximum dose, and then often maybe something else in addition. And they can be a challenge. I don't know if anybody else has experience and strategies or tips for those patients, but I often find that they're essentially getting a mouthful or two of pills twice or 3 times a day, which can be tough to keep up their appetite or just keep the owners on board.
I agree with that. And without a feeding tube, as you mentioned, that it's really hard that many of those, we have had feeding tubes and been able to have many of the medications compounded to get around that, but then that adds expense too, and it's not without its own headaches. So yeah.
Somebody had asked, Kelly asked a question regarding use of calcitriol in dogs versus cats, and I wasn't sure if people were approaching cats any differently. Personally, I don't. I kind of look at them the same. And I think from the literature perspective, I think we have one study in cats that was a short-term study. And I think this might have been a paper that Dennis was involved with. I think it was 2 weeks of calcitriol supplementation, and it did not have an effect on their PTH. And certainly a lot of the limitations were maybe this is the wrong dose, maybe it's not long enough, but it failed to show any documented improvement. So I personally approach cats the same way as dogs, and wasn't sure if anybody else is looking at dogs or cats differently when it comes to management of their renal secondary hyperparathyroidism. Jessica Quimby has wrote in the chat that, to her, that there's poor evidence and it's a lot of hassle and expense that comes along with it. And I think that is might be an overriding theme to the management of these patients. You know, even for the patients that we can control their phosphorus, and we think that we're doing a great job in that regard, we've yet to document that controlling their phosphorus and even controlling their PTH is necessarily associated with an improved survival in our patients that I'm aware of. Certainly, I might be missing some literature that's out there, but we feel better. You know, I feel great when I get that phosphorus down in the 5s, but does that mean my patient's going to have an improved survival? I like to think that it does, but I don't know of any evidence that shows that that's the case. I don't know if anybody is familiar with any studies that have actually looked at the effective therapy on long-term outcome, but I'm not aware of any.
Sean Hillick wrote, is there any evidence in human medicine or literature that suggests that vitamin D improves outcome? This paper does cite a few. I don't think that there's incredibly strong evidence that specifically, okay, if we give X amount of vitamin D and get their 25-OH levels up to whatever, they're going to have an improved outcome. But the main paper that they cited in the Parker et al. Paper was by Ravani et al. From Kidney International 2009, I believe, which showed that 25-hydroxy vitamin D plasma levels was an independent inverse predictor of vitamin D progression and death in patients with stage 2 to 5 chronic kidney disease. I don't know if anybody else has anything to add to that.
Yeah, I don't think I can quote the papers in humans off the top of my head, but I do believe that there's more substantial evidence that controlling phosphorus, controlling vitamin D is associated with positive outcomes. But I think we also have to recognize that people with end-stage renal disease, they're often dying of their cardiovascular complications, obviously decades into the management of their disease. And I don't know if our patients really experience those complications to the same frequency and to the same severity. I don't know if they just live long enough with their CKD that I have to worry about some of those cardiovascular problems. And certainly it's been shown, and I think within that huge table of the effects of calcitriol, it included many factors that are involved in cardiovascular health and vascular stiffening. And I think some of the survival benefit in people has been shown to be associated with improvement in some of those cardiovascular outcomes, which I think in our patients, I'm losing most of my patients due to uremia more so than secondary effects of their hypertensive state leading to cardiac remodeling and congestive heart failure and much of those common outcomes that are seen in people.
I think Dr. Cook, oh, sorry.
No, go ahead.
Go ahead, JD. I was going to say Dr. Cook, I think, made a really good point that so many people with bad CKD are on dialysis, so we're kind of ameliorating their uremia to some extent with that. So I think that's kind of also another good point to think about.
Right. And it should be pointed out that certainly while dialysis can help control phosphorus concentrations, it does not do it adequately enough that those patients no longer need to be on phosphate control, both in terms of their diet or phosphate binders. So patients that are having end-stage renal disease, humans that are dialysis dependent are still taking, a couple mouthfuls of medications multiple times a day to help manage that because there's not enough ability to clear the phosphorus to put them in a neutral state. And I think Jenna had also pointed out too that there are several papers in human side of things that show positive phosphorus balance leads to worse cardiovascular outcomes, which is the interesting point, as Dr. Cook also mentioned, that most people with bad kidney disease die of disease complications related to, but not specifically due to their kidney disease. They're not dying because of their creatinine is 10 and their potassium is 10. Those patients are getting dialyzed or they go into hospice care. Our patients are managed conservatively until we kind of lose that ability to give them that quality of life any further. Daniela asked, would we use calcitriol for patients with iris stage 4 who have rubber jaw? And I'll say that I've only seen a handful of patients with significant renal secondary osteodystrophy, and those patients that I've observed have typically been patients who've had congenital kidney disease that have had abnormal phosphorus and likely PTH levels throughout the course of their skeletal system maturing, and those are the ones that more often were affected with secondary fibrous osteodystrophy. And for those patients, I really evaluate everything globally. I want to see what is their ionized calcium concentration, what's their phosphorus concentration, what's their PTH, and almost universally you're going to see that their PTH level is high, their phosphorus level is typically high, their calcium level, often in my experience, it's been normal. So in those patients, I've tried to reduce their PTH by controlling their phosphorus. And if I get their phosphorus down into the reference range, then I personally consider that as a time that I could consider a drug like calcitriol. I could also consider a drug like cinacalcet, depending on what their calcium status is. But again, I still struggle to get their phosphorus controlled. And personally, I don't turn to calcitriol until I can get their phosphorus reasonably controlled. But again, maybe I need to revise my practice patterns, but that's just kind of the way that I've typically approached it for the most part. Out there who's routinely using calcitriol that can provide some kind of anecdotal feelings on it. You know, I don't have a lot of stories to share about it other than a few handfuls of patients that I've seen over the years. But again, I'm not using it routinely. Is there anybody who uses it frequently that can add some insight onto what they're seeing in patients? And Jessica brings up a point that even if we need a supplement, do we even know the right type of supplement? You know, based upon some of the work that Val and her colleagues have done, should we be using calcitriol? Should we be using other forms of vitamin D supplementation in these patients? And I think that's not even completely well established in humans. What formulation is best? And I certainly think it remains a huge question in our patients, what formulation is going to work the best overall. Yeah, I guess Dr. Cook had proposed, you know, can we try a poll where everyone does yes or no? And I think theoretically, sure. I don't know if I can create a poll as in the middle of everything, but I will try as we are chatting. So give me 1 second. Let me see if I can do that. I think maybe I just made a poll. Okay. I just did apologize for the typos. Do you use calcitrio, which obviously means calcitriol? Do you use it routinely? So I think you can go to the kind of the instrument cluster panel, and then you can just click one of those two. And thank you, Dr. Cook, for encouraging me to learn this technology better, because I've never done that before. Lots of people have just wrote into the chat that they don't. And in fact, I think, we have very few people, with the exception of the hypocalcemic patients, that are using it. And based upon the poll, it looks like we only have 2% of our people that are using it routinely, and 98% of everybody is saying that they do not, which is interesting. I think I guess that's maybe why we don't have as much feedback on, is this something that routinely we can have some anecdotal experiences to share. So I think it's a great topic, and I think we'll probably leave with a lot more questions than answers here. And I think it's something hopefully we'll continue to learn more about. But yeah, it seems like amongst the people we have here, it's not something that's part of routine management of our chronic kidney disease. I guess on the topic, what drugs are people turning to more commonly for controlling the phosphorus once they've maximized the dose of aluminum hydroxide? Are people just dealing with it there, or if you are using second drugs, and what drugs do you tend to be reaching to? And I guess I can make a poll for that too. So I guess give me a minute and let me try that again. Okay, I think I can now try the other one. And I would agree with what Larry suggests, that both sevelamer and lanthanum are quite expensive, and I find that for many pets, especially anything Labrador size and above, they become really darn expensive, which is challenging, to help manage them with a drug that might cost several $100s a month. Lanthanum used to be very, very inexpensive. I mean, it's just a mineral that is mined and was first marketed as just a byproduct. But then once it was found to have medical effects, the cost of lanthanum has gone up dramatically. But
JD, what is the third option there?
Sorry, cinacalcet. Yeah, so
Okay.
cinacalcet is for people who haven't used it before. Cinacalcet is a calcium. It's a calcium mimetic, so it will stimulate the calcium sensing receptor of the parathyroid gland as a way to help reduce the PTH level. It will also help. As a side effect, it helps lower the calcium level, which I think is an unlikely scenario when we have the hyperphosphatemic and hypercalcemic patient. Those patients, I think, can respond best to cinacalcet. Also expensive. I think the trade name in people is Sensipar, and I've used it in probably 5 or 6 patients. I think maybe half of them were probably dialysis patients as well. But I think if you have the hypocalcemic patient, as you were discussing, Larry, it would be the wrong choice, because if anything, it could cause your calcium to drop. But for those hypercalcemic, hyperphosphatemic patients, it actually could be a good option. So it seems like it's kind of split between using the calcium-based phosphate binders and using lanthanum. Personally, I would turn to lanthanum as my second line agent too. I should have put cevimeline on here as well too. I might turn to that as well. It really comes down to the cost. If one is cheaper than the other, that's what I'll use. And depending on the size of the animal, sometimes one is cheaper than the other. But I personally use lanthanum and cevimeline pretty interchangeably as my second choice drug, unless they're hypocalcemic, and then I'll add in the calcium-based phosphate binder personally. Are there other drugs that people have tried? I know Jessica published the paper looking at sucralfate that anecdotally had some benefits of having phosphate binding properties, and her paper showed that it didn't. And in fact, the cats that got sucralfate actually did a bit worse. I think they had more constipation and GI problems with it. So I don't use sucralfate. There's some literature in people showing that niacinamide could help. And unlike our phosphate binders that will form those complexes with phosphorus and prevent it from being absorbed in the GI tract, niacinamide will inhibit the NaPi2b and maybe 2a transporters, which are responsible for the active transport of phosphorus. So that doesn't have to give the we don't have to give that with food as a way to manage their phosphorus, but we don't really have much. I don't think anyone's looked at it, phosphorus concentrations in veterinary medicine with it. They do use that medication for dermatology to treat various immune-mediated forms of skin disease. So it's used, but like many dermatologists, they're not getting phosphorus concentrations before and after its administration. So I wish that we had some data to potentially to back that up. But I think I've used it in maybe 2 patients, and I don't think I was really impressed with the outcome with either. But that's something that is also reported to be used in people, not very frequently, but it's there. I don't know if anybody has used niacinamide for the management of hyperphosphatemia in any of these patients. Yeah, my wife's a dermatologist here, so I just need to convince her to measure a phosphorus before and after she tries using it. So maybe we can get some information for that, because I think it would be, it has the potential to be just a different mechanism, and especially if it doesn't have to be given with food, that's nice to have that as an option to potentially control our patient's phosphorus rather than having to only give these meds with the food, and then that might affect their diet. And then we all know how challenging it is to keep these CKD dogs and cats eating really well. So something certainly that probably could be tackled with a couple people getting together and doing a study. So let's do it. That sounds fun. All right. Is there any other thoughts or any other questions or comments on management of renal secondary hyperparathyroidism or anything like that? All right, well, I think this was great. This was a wonderful discussion. I thank everyone for attending and participating and opening my eyes to the poll feature. I think maybe we'll try that a little bit more with some discussions for our future sessions. So I'd like to, I hope everybody was able to get in. I apologize for just the way that we're going to be doing the registration from here on out. I think it just allows people to be able to sign up because we had so many people that signed up for Journal Club, they were unable to. So we don't have anybody who signed up for the next session on the 20th of November. So that one, unless it's filled, over the weekend, will probably be an empty session. But we do have Dr. Specht discussing NSAID use in feline chronic kidney disease for our December 4th session, which is great. And Dr. Kendall will be presenting urinary incontinence in male dogs at the session later on in December. So we're finishing out the year with some really great presentations, and I'm excited for that. I will send out the link to register for the next session through the ASVNU listserv. So if anybody has joined in from the ACVM post, just so I'm not inundating your email with more posts, I'm just going to be sending the link out through the ASVNU listserv, which if you're a member, you'll get. I also post it to the website. So if you don't want to become an ASVNU member, which I would encourage that you should consider, you can still register by going to the asvnu.org website, going to Journal Club, and then clicking on register. That will be updated for each session. So keep an eye out for that, and I will submit a new sign-up sheet for the next calendar year for folks to sign up so we can get that going. But we have some great presentations coming up in December, and I'm really looking forward to that. Caitlin, thanks so much for your presentation today and leading everything. It was terrific, and I hope everyone has a great weekend and look forward to talking to you in a couple of weeks.
Thanks, everybody. Have a good weekend. Bye.